Acid-base physiology, it's a very informative topic. Okay, when there is a patient comes to you in the emergency, so first of all you will perform ABGs, arterial blood gases, to check out the concentration of oxygen, pH of the blood, and carbon dioxide. So when there is decrease in pH, that the normal value is 7.45 to 7.35. So when there is a decrease that is below 7.35, so that means there is a decreased pH and decreased amount of carbon dioxide and decreased bicarbonate ion. So that condition will be known as metabolic acidosis. So in metabolic acidosis, there can be a compensatory response that is hyperventilation. Alright, there is another condition that is metabolic alkalosis. In this condition, there will be increase in pH, increase carbon dioxide, and increase HCO3. So this condition is known as metabolic alkalosis. In this condition, there will be a compensatory response that is hypoventilation. The third condition is respiratory acidosis. So in this condition, the pH will be low and the carbon dioxide will be high, and HCO3 will also raised. So this condition is respiratory acidosis. There will a compensatory response by increased renal absorption. So the normal generally there is greater than 30 the amount of HCO3 in the blood. So when there is respiratory alkalosis, there will increase in pH and decrease in carbon dioxide and HCO3. So the compensatory response will decrease in renal HCO3 reabsorption. So the normally the HCO3 concentration will below 18. So as you can see, when there is all the arrows in the same direction, so that condition will be metabolic. If they are down, so that is acidic or metabolic acidosis. All the arrows again in the same direction, but in the alkalotic state, so that is metabolic alkalosis. When the arrows are reversed, as you can see, these are reversed, so that is respiratory, either it's acidosis or alkalosis. So here the pH is down, so that is why this will be respiratory acidosis. So again, the arrows are in reverse direction. Reverse is R is for reverse and R is for respiratory. So here the pH is high, so this condition will known as respiratory alkalosis. So when we will check the arterial pH, if the pH is below 7.35, so that condition will known as acidemia. So when there is acidemia, we will check carbon dioxide. When the amount of carbon dioxide is raised above 45 mmHg, so this condition will be respiratory acidosis. So in this, renal compensation requires at least 3 to 5 days to have maximum effect. In acute form, less than 8 hours, there is no renal compensation and HCO3 level less than 30. So in chronic form, greater than 24 hours, renal compensation can start and HCO3 greater than 30. Alright, so these are the causes of respiratory acidosis. Here is airway obstruction, acute lung disease and chronic lung disease, opioids and sedatives, weakening of respiratory muscles. So the opioids suppress our respiratory center, so that will lead to hypoventilation, while on the other part of acidemia, when there is decreased amount of HCO3 below 20, So that condition will known as metabolic acidosis. In metabolic acidosis, we will check anion gap that is equal to sodium minus into chloride ion minus HCO3. So when the anion gap is above 12, so that there are the causes that will cause increased anion gap. The mnemonic is mud piles. So the first is methanol, uremia, diabetic ketoacidosis, propylene glycol, iron tablets, lactic acidosis, ethylene glycol, salicylates. So due to increased organic acid, excess hydrogen ion is balanced by HCO3, but anion component is still present in blood, so increased acid anion component relative to HCO3. So when there is a normal anion gap that is 8 to 12 milliequivalent, so the normal anion gap, the causes can be hyperventilation, Addison's disease, renal tubular acidosis, diarrhea, acetazolamide, spironolactone, and saline and infusion. So the mnemonic is HARDUS. Due to decreased HCO3, so kidney can increase chloride absorption that will lead to normal anion is hypochloremic. So on the other hand, when there is increase in pH that is above 7.45, this condition is known as alkalemia. So in alkalemia, when the carbon dioxide is less than 36, so that is known as respiratory alkalosis. The causes can be hyperventilation. In hyperventilation, there will be hysteria, hypoxia, that is on high altitude, and salicylates, tumor, and pulmonary embolism. So while there is decreased HCO3 concentration, so this condition will known as metabolic alkalosis. In metabolic alkalosis, there will be hydrogen ion loss and HCO3 excess. So the causes can be loop diuretics, vomiting, antacid use, and hyperaldosteronism. So as we know, the loop diuretics helps in the diuresis, so there will accumulation of HCO3 ion and the loss of hydrogen ion. So while on hyperaldosteronism, so we know the function of aldosterone, they work on collecting tubule and they helps in the excretion of potassium and hydrogen ions, so that there will be HCO3 accumulation, so that will also lead to metabolic alkalosis. Another topic is about renal tubular acidosis, a disorder of renal tubules that leads to normal anion gap, hyperchloremic metabolic alkalosis, acidosis. So the first is distal renal tubular acidosis type 1. In this condition, the pH of the urine will above 5.5, defect in ability of alpha intercalated cells to secrete hydrogen ion, so that will result in no new HCO3 is production, so that will lead to metabolic acidosis when there is no HCO3 ion. So this condition will associated with hypokalemia, and there will be increased risk of calcium phosphate kidney stones due to increased urine pH and increased bone turnover. So how this can lead to hypokalemia, we already studied about that, all the physiology of alpha intercalated cells and principal cells and beta intercalated cells. So how when there is increased hydrogen ion secretion, there is increased potassium secretion, so that is why there will be hypokalemia. So the causes of distal renal tubular acidosis can be amphotericin B toxicity, analgesics, nephropathy, congenital anomalies, or obstruction of urinary tract. The second is proximal renal tubular acidosis. In this condition, the urine pH can be less than 5.5, so there will be a defect in proximal convoluted tubule HCO3 reabsorption. As we know, HCO3 is reabsorbed mostly in the proximal convoluted tubule, so that will result in increased excretion of HCO3 ion in urine and subsequent metabolic acidosis. So the urine is acidified by alpha intercalated cells in collecting tubules. So this condition is also associated with hypokalemia. There will be increased risk of hypophosphatemic rickets. The causes of this condition is Fanconi syndrome, we already studied, and carbonic anhydrase inhibitors. We already discussed about that because the carbonic anhydrase inhibitors also work on the sodium hydrogen ion channels in the proximal convoluted tubule. So the mechanism we already discussed. The last condition is hyperkalemic renal tubular acidosis type 4. In this condition, the pH of the urine will less than 5.5. There will be hypoaldosteronism. So when there is hypoaldosteronism, that will result in hyperkalemia. While there is hyperaldosteronism, that will lead to hypokalemia. So here is a reverse form. When there is hyperkalemia, so decreased ammonia synthesis in proximal convoluted tubules result in decreased ammonium ion excretion. So when there is decreased NH4 excretion, so here is type 4. So you can remember that by remembering these 4. All right, the causes of this condition can be decreased aldosterone production, like in diabetic hyporenism, ACE inhibitors, ARBs, NSAIDs, heparin, cyclosporine, adrenal insufficiency, or aldosterone resistance, like potassium sparing diuretics, nephropathy due to obstruction, and trimethoprim and sulfamethoxazole.